Now, as much as we see these injuries on quite a regular basis, they are actually quite rare injuries. And just by way of figures, the hottest here, these are figures from a couple of years ago, about 5 years ago. We're up to 15,000 now patients per year, but this was when we were at 13,000 patients per year that present to the trauma unit. And of those, only 1% actually sustain an acetabulum fracture. So we see about 150 patients per year with an acetabulum fracture. And of those ones, then probably around 50 are treated operatively, which averages 1 patient per week. Of course, it could always be much more than that in terms of the surgical intervention, but of course, we have limitations in terms of theater availability, so we don't operate on many of the ones that we could operate on. And certainly the ones, who are, 50-50, then it just depends on our theater load when the patient comes. So we could operate on more, but like I said, we've got limitations. And again, by way of comparison, if you take all our orthopedic procedures as a department, only 2% actually are fixation of acetabulum fractures. Look, of course, but those figures are a little bit better now because we've got far more theater time than we did probably 6-7 years ago when I looked at the figures. So now, acetabulum fracture patients, really they present in 2 broad groups. It's often young patients following high energy trauma, and that's certainly what we are mostly faced with in our clinical environment. But then there's the elderly population, and of course they present with low energy injuries, and they've got poor bone stock. And it's something that is definitely grown over the last couple of years, also because of the increasingly aging population. Patients are living for longer, and also they demand far more from their doctors, and they're far more physically active and demanding than they were many years ago. So these fractures really present a challenge to orthopedic surgeons. Firstly, because they're often polytraumatized patients, and and most of us, of course, are not in the trauma unit when the patient presents. So by the time they call you, you're often quite low in terms of the clinicians that have seen the patient, you're almost bottom of the food chain. And of course, the damage to the articular surface happens at the time of the injury, and it is often irreversible damage. And now the anatomy that is required of you to understand is very complex, and you need detailed grasp of that 3-dimensional anatomy of the pelvis. Surgical access can be difficult, and as I often comment in theater, that the biggest problem with any surgery actually is access. Once you get to the fractured bone, it's often easy to know what to do, but getting there is often the most difficult part. And certainly I'm going to show you some slides later on of the structures at risk. Not only is the presentation difficult, the surgery difficult, but the rehab as well, is quite prolonged. And like I said, these are often polytraumatized patients. They don't go home immediately. They go via step down, and even the step down, the physios are not always sure exactly what to do, how much range of movement to allow them, how much weight can they tolerate. So your involvement doesn't really end at the time of the operation. And of course, the operation, the complications can be quite severe. It's often said that if you are scared of big complications, then you mustn't do big surgery. And it's certainly true when it comes to to the pelvis. Fortunately, infection is not a major problem, because the pelvis and the sternum are quite well vascularized, but your other complications excuse me, like you know, heterotopic ossification, afterwards osteoarthritis, you know, blood clots, DVT. You know, so those are the issues that you're dealing with mostly, and of course loss of reduction. And as with any articular injury, if you lose reduction after a primary intervention, it's very difficult to salvage afterwards. Now, in terms of anatomy, so as you all remember that the innominate bone is really formed of three components. So all these components then contribute to the acetabulum. And of course, when we talk about the acetabulum, remember we're talking, you know, about the weight-bearing component, which is got the, or rather, we're talking about the articular component, which is got the cartilage, because the same bone also forms part of the pelvis ring. So there's three bones to it. So the ilium, really contributes the dome in the cartilage. The ischium contributes the posterior wall and posterior column, and the pubis contributes the anterior wall and the anterior column, as you can see on the illustrations. And actually these ones, if you look at this, they are very similar to, if you remember your triradiate cartilage in pediatrics, it really just, even when it fractures, it tends to fracture along similar lines as your pediatric skeleton. And then there is the two-column concept, which basically divides your acetabulum into the anterior column and the posterior column. And like I said, that's mostly the ilium and ischium at the back, and then the pubis anteriorly. So, like I said, of course, this is all three-dimensional, so you need to appreciate the other parts of the pelvis. But of course, your difficulty is not limited to the bony component only. The muscles come into play and the ligaments to make it more interesting. But in terms of surgical access and mobility, of course, the biggest component is the blood vessels and the nerves. But luckily, with acetabulum fractures, unlike pelvis ring injuries, death is not often a problem on its own. Bleeding is not often a problem in acetabulum fractures. That becomes a problem in pelvis ring injuries. And you need to differentiate the two in your mind. Now, with X-ray evaluation, you know, this is a little bit historic, but you know, you will still have many examiners, importantly, who are going to ask you about the Judet views. In our setting, of course, we do the low docs most of the time, and from low docs straight to CT scan. But the beauty of the CT scan is that you can then recreate with your MPR, you can recreate some of these views. But traditionally, it's been the AP view, which is adequate in 90% of the cases to assist you with the diagnosis. Then we do the iliac oblique and the obturator oblique view. But it's important that when you do the Judet views, you know, you don't turn the machine, you have to turn the patient, and you can appreciate that it's a patient who's just come in still extremely tender. So they're not necessarily the best views to do in the initial trauma presentation, but of course they become important post-operatively and also getting your follow-up. So this would be, I'm going to show you X-ray examples of this, but this is the obturator oblique view, because you can see the obturator foramen nicely. And then this is the iliac oblique view, which shows you the entire iliac going like almost perpendicular to it. And I'll show you what each one of those things mean. So when you're presented with, so now this is when I often in the meetings say to you, you need to draw the lines so you can understand exactly what you're talking about. So line number one, so that's your iliopectineal line, and it basically starts at the sciatic notch. Oh, sorry, I'm pointing at the wrong place. Starts at the sciatic notch there at the top and goes all the way down to your pubic symphysis. And any break in this line is consistent with a break in a break in the anterior column. So if you see a break in the iliopectineal line, it means the anterior column is involved. And just to emphasize, it's better to say that the column or the wall is involved when you're still going through the classification. Don't say it's fractured, because if you say it's fractured, then in your mind, you have to include that component in your classification. So if you say the anterior column is fractured, then you're going to look for a classification that includes anterior column somewhere. So you must say the anterior column is involved. Then we go to line number 2, which is the ilioischial line. So that one again starts on the outer part of your obturator foramen, straight up, and also into the sciatic notch. So this line is consistent with any break in the posterior column. Then the teardrop. So teardrop really just certainly the outer part, the inner part of it just represents the most anterior and inferior part of your acetabulum. It's not really important in terms of classification, but you need to recreate it when you're doing the surgical fixation. Then we go to the dome. So you look at the femoral head, look at the cartilage above the dome. So that's number 4, which is the weight-bearing surface. This becomes very important in transverse fractures when you're trying to classify them now, whether they are transtectal, juxtatectal, or infratectal. So the term tectal refers to the weight-bearing surface of the acetabulum. So I'll show you later on that transtectal fractures go through the entire weight-bearing part, juxtatectal just below that, and infratectal below the fovea. Next up, I think it was Kirsty that I spoke to on Monday. You look at the femoral head, okay? Now, behind the femoral head, you're going to see 2 lines, and those lines represent, so the most medial of the 2 lines, because when you're standing, your pelvis is almost at 45 degrees to the person in front of you. So the most inside of the 2 lines is the anterior wall, and the lateral of the 2 lines is the posterior wall. So that's why I said, so any fracture in the wall needs to go in this plane, not in this. So any fracture, of course, that goes in this plane will involve the wall, but it's not a wall fracture. A wall fracture has to remove the wall from the acetabulum. So look behind the femoral head, inner line, anterior wall, outer line, posterior wall. And of course, that's the most commonly disrupted line in your acetabulum. Okay, so that's posterior wall, line number 6. So now, if we go to practice, so of course this is the fractured side, but we'll do it on the normal side. That's your iliopectineal line, which represents anterior column involvement. Ilioischial line, which represents posterior involvement. Actually, I think it's probably time for new diagrams now. I'm sure my drawing technique is much better. Then you look at the dome. So remember, let's say the dome, so the weight-bearing surface, that's the dome. So any fracture that goes through that is transtectal. Any fracture just below that is juxtatectal, and any fracture below that fovea, of course, is infratectal. So you look at the dome, and then now we'll go behind the femoral head. That's the first line. Sorry. So that's your anterior wall. Then again, you can see femoral head, outer line represents the posterior wall. So now when we look at the Judet views, like I said, this is the obturator oblique view. So what it shows you, you've got now the whole anterior column visible to you. So you'll see the anterior column nicely. But importantly, this is your posterior wall or the posterior lip, if you want to use old terminology. So as soon as this fracture here happens in the posterior wall, this posterior wall is often knocked and it sits somewhere behind the head here. So it's very easy to spot in the obturator oblique view. So obturator oblique, anterior column plus posterior wall. Then we go to the iliac oblique, which then shows you the entire posterior column right up to the entire iliac wing. So here you will most commonly see posterior column fractures here, And then, of course, if there's any anterior column, anterior wall fracture, it will then sit out in front. But like I said, luckily, anterior wall fractures are quite unusual. So this is an X-ray example. Now, the beauty with Judet views is that an obturator oblique view of one side automatically gives you an iliac oblique of the other side. So you can always find a side to compare. So of course here, so obturator oblique, but once you do the iliac oblique of the other side, you will then get a normal obturator oblique that you can look at for comparison. So for this one, obturator foramen, obturator oblique view. Okay, now what can we see here? You can see the whole anterior column right up to the sciatic notch. And of course, it's easy to spot here, the anterior column is fractured. You come and look here, there's a posterior wall. Is it involved? Yes, it's involved because the fracture line comes across here, but is it fractured off? And the answer is no. So this is still intact here, but this fracture line continues like that. Okay, so now Kirsty, unmute your mic and tell us what fracture this is.
So it's a anterior column, and with so it's an associated anterior column posterior wall.
No, I just said now the posterior wall is involved, but it's not fractured off. So it cannot be.
So okay, so this is probably a T type.
It's easy. Anterior column involved, yes or no?
Yeah. Yes.
Posterior column involved, yes or no?
Yes.
Difficult to say, but you can say when this belongs there, right?
Yeah. So I would say
posterior column is involved.
Yeah.
So now, once you've got involvement of anterior column and posterior column, immediately in your mind, what must you exclude? Because of course now both columns are involved, I agree. So what must you exclude immediately?
Both column fracture.
Yes. So how do you exclude that?
Well, if part of the acetabulum is still continuous with the ilium, which it is in this case,
yes.
So I would exclude a both column fracture.
So it's not a both column. So now which other fracture types remain that involve the anterior column and the posterior column with a fracture line that crosses like that?
So transverse and a T type.
And the T. So what do you look to exclude the T type?
Well, were you pointing at the inferior ramus?
Because for it to be a T, it needs to come across, not only here, but it must involve that ramus as well. So it should come like that and straight down. So this is a transverse fracture type.
Okay.
So, but if this corner was broken off, then it becomes transverse plus posterior wall.
Okay. All right.
Okay.
I think I'm finally getting it.
Okay. Cool. Alrighty, so now we're going to the classification, and like I said, there are basically 10 fracture types, and you've got the elementary, which mean for all intents and purposes, if you subtract combination, the elementary fracture types only have one fracture line, and they're easy to spot. The only confusing one is often the transverse fracture, but remember the transverse is still one fracture line. It goes straight across. That's one fracture line. So as much as it involves this column and that column, but there's one fracture line, so it's a elementary fracture type. So elementary, posterior wall, I'll show you examples of each one of them. So posterior wall, posterior column, anterior wall, anterior column, and then transverse. Then you go to the associated fracture type, and here it means that more than two parts are fractured. Okay, so it has to be one component and another component. Whereas in the elementary fracture type, it's one component only that's fractured, like I said, plus minus combination, and then of course now add a transverse fracture type. So here you will have posterior column and posterior wall. There is no anterior column, anterior wall, which is what people often say. So it's posterior column and posterior wall. Then you get a transverse and posterior wall, which is extremely common in our setting. You get T-shaped fractures, which are not very common. Anterior column and posterior hemitransverse. These are common in elderly patients, and then of course an associated both column type. Okay, so these are the elementary. So like I said here, there's a single main fracture line. So posterior wall, so only the posterior wall comes off. So there's a fracture line, it just takes off the posterior wall. Anterior wall, same thing. This is the most unusual fracture pattern you're gonna get. So I mean, it's the most rare of the fracture patterns. So it just takes off the anterior column only. Then you go to posterior column, it can exit at the sciatic notch, it can exit a little bit lower, but it's still a column fracture, but the wall or the lip itself is still intact. And then you go to anterior column. So anterior column will always exit in the iliac wing, comes and it removes the entire anterior column from your acetabulum. Okay, and then you get your transverse now, which starts in front, goes all the way across to the back. But importantly, it's one fracture line. So those are the elementary fracture types. Then the associated or combination types. Commonest one here is posterior column, posterior wall. Okay. Transverse, posterior wall. And then you get the T-type. So a T-type is basically a transverse fracture that then exits in the obturator foramen inferiorly. So it starts across all the way down to the obturator foramen. It's shaped like a T. And then you've got now the anterior column, if you remember the fracture line, posterior hemitransverse. So now remember, if it was a transverse, it would come across all the way like this, across. But here, it starts here, but stops here because the anterior fracture line takes it out there and there. So it's anterior column, posterior hemitransverse. Almost looks like a Mercedes-Benz sign. So it goes like that, and posteriorly. Common in elderly patients. And the beauty with anterior column and posterior hemitransverse is that almost always, without fail, the posterior column component is undisplaced or very minimally displaced. So you approach this from the front only. Then you get a both column fracture now, as you can see here. You've got your anterior column involved and your posterior column involved. But importantly now, the two, unlike these two, which join inside the socket and leave this space still attached to the axial skeleton, these two fracture lines join above the acetabulum. So they remove the acetabulum from the axial skeleton. So this is your both column fracture. Okay, who is next? Jonathan, unmute.
Yes, Prof.
Okay, so let's just go through this one now. But what can you see here?
Okay, so it's an AP X-ray of a skeletally mature pelvis. I have to look quite hard to see anything. If I follow the lines, both left and right, so iliopectineal line.
So I'll make it easy for you. Let's stick to the right acetabulum. Okay.
The right acetabulum, yeah.
Okay.
Okay, so iliopectineal line is intact.
Okay, so what is it not?
So the anterior column is not involved.
Okay, great. We come
here. The ilioischial line, it looks intact to me, looks smooth, so it's not involved.
Okay, so that's not involved. All right,
yeah.
So you've excluded a lot of fractures now. Okay.
Yes. Yeah.
All righty, so where else do you look?
Okay, then I'm going to look at the dome. Yeah, it looks like it's flattening a little bit, but probably just some age-related changes. Looks intact to me.
Okay.
Yeah.
Now where else do we look?
Then I can go and look at the teardrop. I can see a teardrop there, and then I can look at the anterior and posterior wall lines.
Okay.
And that's, I think, it looks like there's some abnormalities there. Looks like that would be the most lateral of the two lines. So that would be the posterior wall.
Okay, so if I follow it here, can you see what happens here?
Yes.
Okay, so which is the most lateral of the two?
So the most lateral is the posterior wall.
Posterior wall. Okay, so now what do you think? So what's the classification here?
So it looks like this is a involvement of the posterior wall only. So it's gone in and out in the posterior wall. So I'd call this a posterior wall fracture.
So that's very good. So this is the X-ray that will always be reported as normal by the radiologists. So if you don't have a proper look, this will be reported as normal. And the one thing that will save you from missing it is if you look at this acetabulum here. So you said there are some old age-related changes, right? Now look at this on the left side. You can see the dome, right? Of the two domes, which one looks a bit more sclerotic?
Mm-hmm. Yeah, I think the right looks more sclerotic.
Yeah, okay, look, I mean, I don't know what your monitor looks like, but yeah, so the right one looks more sclerotic. And what do you get when you get two overlapping bone fragments?
You would get relative sclerosis.
Yes, yeah, and then if you look at this here, this is always classical, you always get this triangle here.
Yes.
See where I'm pointing?
Yes, I can.
That's your posterior wall, it's displaced, and that's where it's sitting. And I said most of the time this gets reported as normal, and then these patients only present much later with a destroyed or dislocated hip. So it's quite a huge chunk of the posterior wall. And in the days that we're still doing Judet views, of course, he was taken for Judet views, and that's what you get. Okay, so as soon as you turn him over, it flips out, the hip joint falls out, and you can see, so now this is, what view is this?
So that's an obturator oblique.
Obturator oblique, which shows you?
Yeah. So on the obturator oblique, I'm going to be looking at the anterior column and the posterior wall.
And there it is. Okay, yeah. So you can see the posterior wall with its articular component. Alrighty. So that's what posterior wall fractures look like. And of course, it can be as obvious as that with a dislocation. But so even without a dislocation, if you do an obturator oblique view, there is your posterior wall sitting behind. Okay, so this is abnormal. This should be down here, of course. And you can see the anterior column fracture line nicely. If you CT scan them, again, remove the femoral head from your MPR when you MPR it, and there's your posterior wall involvement. Okay. So now, this is why most people don't do Judet views anymore, because you can manipulate now your MPR image and get this picture, which is an obturator oblique view, and it'll help you then identify the injury. You remove the femoral head or you subtract it digitally. And of course, the beauty of the CT scan is that not only can you diagnose, but you can also quantify. And how you quantify it is, so basically we say if it's less than 20%, then it's a small or insignificant piece. Between 20 and 40, you have to check for instability, and larger than 40 is unstable. But the reality is that if it's less than 20, we call it stable. And if it's more than 20%, I mean, it's very unusual to take a patient to theater and MUA them and not fix them, because also the MUA is a question of how hard you push. Because if you push hard enough, they will all sublux will come out. So how we determine this? You find the middle of your CT scan, try and match the bony columns, and then measure the normal side. So if this measures 10 centimeters from the inside to the outside, then you come onto this side and you measure the length of that piece, and that will give you a percentage of this compared to the whole articular surface. And of course, if it's less than 20%, like I said, it's often stable. Anything more than that is unstable. So this is the view. I think Ronnie's asked me 2 weeks ago how you work out the percentage, and this is how you work it out. Okay, who else? I forgot now who else is online. Ayik, are you online?
Yes, I'm online, Prof.
Okay, let's hear you talk.
Good. So, do you want me to that? So basically, it is
discuss the lines.
Yeah. This is the AP pelvis of a skeletally immature individual. So if I started with the lines, basically let's start from the right side. I would say, if I could say, there's iliopectineal line.
Okay, let's follow it.
Yeah, it looks there is something going on there.
You think there's something going on? Okay, fine. Where else do you want to go?
So then let us go to ilioischial line. Ilioischial line. Yeah, also ilioischial line. There is a step there.
Okay,
On ilioischial line.
Okay, so that's definitely gone.
Yeah.
Alrighty.
And then you can just
Now,
look here.
wait. So now, so you think the anterior column is involved? You think the posterior column is involved?
The column is involved, yeah.
So where do you look immediately?
So immediately I would look to the, I would look up to the ilium.
Any fracture?
No, I don't.
Okay.
Yeah, I don't see fracture.
So what is it not?
So if it's not, so that is mean the two columns are not associated. There is no association of two columns.
No,
there is no anterior.
No. There's no. It is not an associated both column fracture.
Yeah.
But there's no fracture line here. But you said both columns look like they're involved. So you look up and you look down. So you looked up, it's not a both column. When you look down, where do you look?
So you look to obturator foramen.
Okay, is there a fracture?
No fracture.
What is it not?
So if it is not, so that means it is excluding the T type.
Yes. Okay, so now immediately you know that it is not a T fracture, it's not a both column. And also now so this is meant just now for you to exercise the obturator oblique views. So you think the anterior column is involved, you think the posterior column is involved. So now we must give you Judet views now to exclude or to confirm some things. So that's the first Judet view. What does it confirm?
So the Judet view here is confirming that the posterior column is involved, or fracture, I would say.
Is involved.
Yeah, is involved.
Okay. So now, now this is your iliac oblique view. So you agree now that the posterior column is involved.
Yes.
But remember, when you were here, you thought the anterior column was also involved, but there's too much happening here. You're not sure. Now you've got this view. What's this view called?
This is obturator oblique view.
And it shows you the
anterior column.
Is it involved?
Now it's not involved.
Okay. Now remember what I said, that automatically here, when you do the obturator oblique view of this side here, it automatically gives you the iliac oblique of the other side. So you can then, minus some body parts, but you can then see the posterior column of the other side. So you've got this one to compare to that. So you can look at that and look at that. So, okay, fine. I've got a template on this side, and there I can see the fracture. Same thing, you've got your anterior column to compare on both sides. Okay, so now let's go back. So you said here, you thought the anterior column was involved, but now you've seen the obturator oblique view and it's not involved. So now, what does it leave you with? So now classify this.
So it leaves me that is the posterior column is involved.
Yes, and is there anything else that's involved?
So then I need to go and see the other lines.
Yes, so now let's look at the posterior wall. Is involved?
Posterior wall, it doesn't look.
No, not involved. Anterior wall?
Anterior wall is not involved as well.
Yeah, sorry, anterior walls, I must pointing here. Not involved. So now, only one bit is involved. What is it?
This is a transverse.
Yes, Prof. No, you just said now that the anterior column is not involved. So why is it transverse?
No. So that is only the posterior column only involved.
So what is it?
Is the posterior column?
Yes. So this is the posterior column fracture. There's no other line that's involved. Only this one. Okay. Only this one. So that's why I said most of the time you can tell on the AP view But of course, if you can't, then you must get better views, either CT or Judet views. And here the Judet views have helped you.
Yes.
Okay. So we move on. So here, okay, I've labeled this one, so I can't ask. But again, here, you know,
Curator.
there is your dome. No, actually, you can unmute yourself now. So here, and only the anterior. So basically, if you're gonna see subluxation of the femoral head, what actually medialization. So if the femoral head is medialized, usually only a few fracture lines allow that. So firstly, the femoral head cannot medialize if your anterior column is intact. Okay, because that's what keeps it in. So for it to medialize, the anterior column or part of the wall must go. So here, iliopectineal line is intact, iliopectineal line is disrupted, posterior wall is fine, everything else is fine. So here, this is a pure anterior column fracture. And there's your CT scan to confirm that it involves the anterior column, iliac wing, and exits here. There is involvement of this inferior part of superior inferior ramus, but this is not involved, so it will not be a T-type. So even if you look at that, but the posterior column is not involved, so it can't be a T-type. So this is just an anterior column fracture. And that's the Judet view, showing that's the quadrilateral surface as part of your anterior column fracture. And this needs to be reduced immediately because you can see the femoral head is medialized. This is the dome, and that's the head sitting there. And on CT, this is exactly what typically happens, that it almost explodes at your anterior column. And like I said, this is a typical geriatric injury. I'm going to show you X-ray examples of this later on. Okay, so we go now to posterior column and posterior wall. Again, iliopectineal line is intact. There it is. So the anterior column is intact or not involved. Ilioischial line goes all the way, it goes the wrong way completely. So that's disrupted. Now, this is again the point we make all the time. If you look at the femoral head, that's the dome. Okay, so the femoral head cannot be in any other position. It's not subluxed. The only way for it to sit like this is for it to be dislocated posteriorly, because your hip joint is a deep joint and it's got a labrum as well. So the only subluxation you're going to get is if it medializes, or if there's a fragment in the joint and it sits slightly laterally, but it doesn't sublux in any other position. So for it to not be sitting under the dome, it means it's sitting directly behind the femoral, the acetabulum. So this X-ray is dislocated. Don't say the position looks a little bit, maybe it can be improved with traction or whatever. This is dislocated. And then look, there's a posterior wall. So okay, so even from this view, you can tell that that's intact, posterior column is involved, posterior wall is involved. There's no other involvement, so it's a posterior column and posterior wall. So it's an associated posterior column, posterior wall fracture. And once you've reduced it and you do a Judet view, there is your posterior wall fracture that still remains. So this is your iliac oblique, your obturator oblique view. And if you go to iliac oblique, there is your posterior column involvement. That's confirmed. But importantly, like I said, if you look above the dome, look at this. If you see that triangle of bone that you're not sure what it is, it's always the posterior wall that sits above the acetabulum like this, and it forms this triangle here above the acetabulum. So that's a posterior column and posterior wall injury. Okay, we'll move to transverse fracture now. Kirsty, unmute yourself, please.
Yes, Prof.
What do you remember from Monday from this X-ray?
What do I remember? I didn't see this X-ray on Monday, but this is a transverse. Yeah. So it involves the posterior column, and it involves a posterior wall, but isn't defined as a posterior wall fracture.
Yeah. Okay, but what's happening here?
Yes. Yeah, so this is the tilt fracture.
No, the tilt fracture. Tilt fracture exits here. What did I say about a combination of a pelvis ring and an acetabulum fracture?
The killing fracture.
The killing fracture. And if you see this combination, the acetabulum fracture is almost always what fracture type?
Transverse, 90% of the time.
90% of them are going to be transverse fractures. So if you see, so for everyone else, if you see a combination pelvis and sort of pelvis ring and acetabulum fracture, 90% of the time the acetabulum fracture is going to be a transverse fracture. And the combination, of course, I mean, it's a high energy injury to fracture your acetabulum, but now to combine that with a pelvis ring injury, so that combination is called the killing combination or the killing fracture, because you've got two high energy injuries. Now, the thing with the transverse fracture here, so again, for everyone, this is your anterior column that's involved, posterior column that's involved. So this is as clear as you're ever going to get with a transverse fracture. But see how the head is medialized. Now, non-union is very unusual in acetabulum fractures, and the only time we'll get non-union is in a transverse fracture. Because it fractures like this, then the head just medializes, and if you leave it in this position, you get pressure necrosis of the cartilage against this corner, because remember this is very strong bone, so the femoral head cartilage butts against this fractured bone, and there's an impression fracture, almost like a heel sex if you leave it for long enough. So when you see this, you reduce this immediately and you put skeletal traction. And most of them reduce quite well, almost anatomically actually, if you get to them early, because your ligamentum capitis femoris here is still attached. So when you pull the femoral head out, it brings this component with it. And you don't even need to, because the other question is whether you need lateral traction. And the question is no, you don't. Just normal denim pin traction will pull in this direction, which is sufficient to reduce this. So you don't need lateral traction. And of course, for you to do lateral traction, it means you must put your pin exactly where the incision is for the Kochalangenbeck approach to fix this. So that all you're doing is just creating a breeding ground for bacteria. And then the other lesson here is that if you have a combined acetabulum fracture and a femur fracture, when you do the femur, please don't burn our bridges and make incision, because again, your femur incision is going to be here somewhere, which is in the way, or sometimes just slightly off the Kochalangenbeck. So now I have to incorporate incisions, which I would not normally want to incorporate. So better to do a retrograde nail and leave this part here pristine for us to follow. So that's your AP view, and then this confirms. This is now your obturator oblique view, which confirms that there is no exiting fracture in the foramen and your anterior column is involved. That's the iliac oblique, again confirming involvement of your posterior column. So it goes from posterior right across to anterior. So it's a transverse fracture. I know I'm repeating this a lot, but I'm hoping that this will be it now for the next 2 years. I won't have to do this lecture again. CT scan confirming front all the way to back. So transverse fracture. It's yes, both columns are involved, but there's one fracture line. So it's an elementary fracture type. And again, that's just another 3D image. And then on your axial image, remember that your column fractures are always front to back like that. So this is a transverse fracture. It involves your anterior column and posterior column. So it goes, so on the X-ray, it goes across the screen, like that, across the screen on X-ray. But on an axial CT, it goes up and down, because remember, it's front to back, and front to back, right? Right, now I spoke about the different components now of the transverse fracture. So if it exits right through the dome, that's called transtectal. So tectal means weight bearing. If it's just between the weight bearing surface and your that horseshoe where the fovea goes, that's juxtatectal. And then if it's below the fovea, then it's infratectal. So now this is again anterior column. I'll go a little bit quicker now. So anterior column involved, posterior column also involved. So you can see this fracture line goes from front all the way to the back. But what else can you see here? You can see now this thing here above the end. So if you see that, it's almost always the posterior wall that's just been pushed up. And that's your obturator oblique confirming. What does it confirm? Mohammed, unmute.
Yes, Prof.
What's happening with the hip joint here?
The hip joint, it looks dislocated, Prof.
Why do you say that?
Because if you look at the dome, the head is sitting slightly proximal to the dome.
Yes, perfect. So now when you go back to the AP, where's the dome?
So the dome is here.
And the head there. So this is, because remember that if it's a transverse where it breaks off the dome and goes with it, the dome will follow. But here the dome has stayed behind. You understand? Let me just go back here quickly. So you see here, it's not, so it's pushed the whole thing with it, but it's not sitting behind the dome. Okay? So there's a bit of the cartilage there, it's followed the head. So this is not sitting at the back, whereas if you come here, the dome stayed behind. And there's a femoral head, there's the wall. And again here you can see nicely, that's the head, that's the dome. So this is dislocated, and that's the wall. So transverse plus posterior wall. And of course it wasn't appreciated, and it was sent to CT scan, and it was CT scanned in a dislocated position. That's dislocated. So transverse plus posterior wall. Okay, so you just got to look out for these not so obvious dislocations. Both column fracture. So here, anterior column involved. Yes. Posterior column involved. Yes. And then immediately we'll look. You can look there if you want. It's like, if that's involved, could it be a T? Possible. But now if you look there, there's a fracture in the iliac wing which separates the acetabulum from the weight bearing, from the rest of the skeleton. So this is an associated both column fracture. It means that the entire acetabulum has been separated from the rest of the pelvis and axial skeleton. That's the other view. Iliac oblique, again, posterior column confirmed, but there's a fracture line in the anterior column or in the iliac wing that just confirms that this is now separated. Okay, so now, I don't know who else is online. Peter Fenter, if you're online. Is he?
Yes, I'm here, Prof.
What is this called?
Posterior wall.
No. Anyone? In a both column fracture, what is this called?
Spur.
Oh, the spur, yeah.
It's called the spur sign. Okay, so this is the spur sign. And the significance of it is that in a both column fracture, if you look there and there, so this whole bit of the acetabulum has been separated from the axial skeleton. This is the last bit of the skeleton that remains attached to the skeleton and is in anatomical position. Everything else has moved. So when you reduce this fracture, you reduce it onto there. So that's the spur sign. And you only see it on the obturator oblique view. So there's obturator oblique view and there's your spur sign. So you can see this whole acetabulum has been medialized, and all of this, that belongs there. Now there's also another phenomenon that is sort of almost demonstrated here, where the relation of the femur to the acetabulum looks fairly well maintained, even though the whole thing is medialized. So what do you call this phenomenon? Anyone?
Called secondary congruence, bro.
Yes, so this is secondary congruence. So acetabulum is fractured, the whole thing is medialized, but the relation now of the femoral head to the cartilage still remains fairly well preserved, and this used to be an indication for non-operative treatment, But of course, we know that the hip mechanics are messed up here because the whole thing is medialized. So I mean, we don't teach it non-operatively anymore. But of course, in elderly patients, you could use that as a reason to not treat them operatively. So yeah, just to confirm, so that is your spur sign. Now, so I'm just taking you through how, I go through them, but there are many ways you can approach your lines, and this is an article that's worth reading, where you can diagnose it by going for what you see, or you can work by exclusion. It's entirely up to you, but ultimately, you must just get to the correct diagnosis. Okay, this is what I used to do photography. I was once creative before I became an orthopod. Okay. Okay, so I'm going to end it there, and I'm going to take questions before we move on to the next part. Questions?
Prof, could you point out a gull wing sign in any of those fractures?
I didn't because I don't. Actually, I have a gull wing in my last presentation. Yes, I'm going to show you on that one. So basically, what it means is, I mean, as you know, it's just impaction of the anterior column that you get in an anterior column posterior hemitransverse fracture. It's a geriatric injury. So when I get to my last presentation, I'll show you the gull wing sign.
Thank you.
Prof, can I ask you a question, please?
Yeah.
So just in terms of outcomes, what is the poor prognostic factors on the CT scan or the X-ray for patient with acetabular fracture?
Okay, so the worst possible prognosis is a comminuted posterior wall fracture. So, as much as you think that, posterior wall is the commonest one and it's what we treat commonly, it's fine if it's not comminuted, but the minute you have posterior wall comminution, or, almost similar to the knee, where you've got rim fractures of the posterior wall, which are difficult to fix surgically, that's always a poor prognosis. Then the next one is, because it's such high energy, is a combination of a transverse plus posterior wall. So that also carries a poor prognosis. And then in terms of the geriatric fractures, the one with the worst prognosis, again, is a anterior column, anterior wall on its own, because it's very thin bone, very difficult to fix. And then an anterior column, posterior hemitransverse, if there is the gull wing sign, because the gull wing represents articular impaction, and I'm going to show you that later, and that is very difficult in elderly patients. And then lastly, again, in elderly patients, once you've got impaction fractures of the femoral head, from as part of the acetabular fracture, but also in young patients, if you have an unreduced transverse, where you then get that impression fracture. So those are the signs of poor prognosis on X-ray and CT scan.
Okay, thanks, Prof.
Okay.
Prof, I have a question as well.
Yeah.
Yeah, Prof, for those, if you think the patient has got a poor prognosis, do you go immediately for arthroplasty to treat these patients, or you just leave them to heal and then later on you fix them? What do you
look? So it depends. Now the two components, when I answer that. One, in elderly patients with very poor bone stock and very poor prognosis. So in those ones, you know that fixation is going to fail because of comminution, or because of impaction fractures, or because of very poor bone stock. Now, if you fix it, you know it's going to fail. And at the same time, you know that the elderly cannot do touch weight bearing or non-weight bearing. So if you fix it and you send them out, the whole thing is going to collapse. So in them, we do what's called fix and replace. So you fix the columns just to get bone stability, but then you put a hip replacement immediately with multiple screws, a sector type cup. So that's called fix and replace. So that's how we do it in the elderly. In young patients, look, if someone comes in with some signs of poor prognosis, in young patients, you're always tempted to fix them because, firstly, you want to have enough bone stock to work with, once the hip is distorted enough to warrant the hip replacement. But then also because, of course, if you're 30 and you get your primary hip at 30, by the time you hit 70, 80, you will have gone through a number of revisions. So we try and preserve bone stock and save the native joint. And of course, if you fail and in 5 years' time you have to change to hip arthroplasty, that's fine if you're young. But in the elderly, they don't have that time. Because also remember that if I'm 85 years old and you confine me to bed for 3 years or to a wheelchair for 3 years, that's a massive percentage of my life remaining for me to not be active. Whereas if I'm 20 and you say, okay, for 2 years, let's give it a try. If it fails, we'll convert to arthroplasty. You've only lost 2 years out of the next 75 years of your life. So you've got time to wait in young patients, but in elderly patients, there's no luxury of time. You want them to walk immediately. So we fix and replace in that group. Okay.
Thanks. Thanks.
Okay, shall we move on to the next one? Okay, let me find it. So share screen. Okay, sorry, 1 second. Okay, can you see the main presentation screen?
Yes, Prof.
Okay, thank you. Alrighty, so we're going to move on quickly just to indications and technique for iliosacral screw fixation. Why is it not moving? Okay, so actually I put this thing up now just to remind cronies that, look, I'm gonna be away this week, but the week after you promised us, a trip up a hiking or running trip up the mountain. So you need to follow through with that. No more excuses, cronies. I don't know if he's online or not. But anyway, here's our lovely hospital, and obviously I gave some of this talk overseas, so I tell them about the history of the hospital. But importantly, so for this talk, we're just going to discuss the most, again, typical things when it comes to iliosacral screws. We'll discuss the indications. We will discuss the preoperative imaging, surgical preparation, and then I'll touch really only on the percutaneous technique, and then along the presentation, I'll try and answer some of the most commonly answered, most commonly asked questions. So our story begins with a Canadian tourist who decides to climb Table Mountain. And so that's the route that he took up. And he got to the top. Of course, happy and impressed with his achievement. He decides this was too easy for him. And he sees this sign that says this is not an easy way down. And he figures this is the way that he's going to take. And needless to say, didn't end well. And that's what happened to him. Fell off Table Mountain. And of course, if you're gonna help or see patients rescued off Table Mountain, they're either gonna end up at Posterior or most of the time Palotti. So he came to us, and that's what he presented with. I'm not gonna ask you the classification now, but basically that's the front lesion and that's his posterior lesion. Not too dissimilar cronies. I think it was Peter Fenter and cronies today that showed me a similar x-ray that we're doing next week. So it's a type C pelvis injury with disruption, complete sacral fracture at the back, and it goes all the way down at the entire sacrum. And then the anterior pelvis ring is also involved. So just briefly now on the classification. So when we say it's a type C, it means that, conceptually, if you were to apply a rotation force onto this pelvis, would it displace, or rather would it rotate? And the answer is yes. So we know that it is rotationally unstable, So it's a Lisa type B. And then if you were to apply enough force to pull the right hemipelvis, would it move superiorly or inferiorly? And the answer is yes. So it is also vertically unstable. So that's why I said it's conceptual. It's a conceptual classification based on what you see. But of course, if you want to prove it, you can then take them to theater and do the actual application of the force. So it comes with the type C fracture of the pelvis. Now, what are the indications? So we do the technique for pure sacroiliac dislocations or for sacral fracture dislocations. Now, these are the CT examples. So this is what a pure dislocation is going to look like. And then here, you've got your dislocation still, but you've got this fracture. So now, who shall I pick on? Santa? Oh, I haven't seen Santa in ages. Santa? That's yours. What do you call that?
Hi, Prof. So, Prof, that is a fracture through the SI joint on the
No,
left.
it's got a name. I'm looking for the name.
Oh, geez. I don't know, Prof.
Too much hands. Okay, Blankson.
Hello, Prof.
Hi. Whoa. What's that fracture called?
In terms of classification, I'm not sure if it's going through the.
What is the fracture called on the right?
On the right, Prof, I'm not sure.
Who else? Who's Killian. Let's hear from Miss London. Killian?
Prof, how are you?
I'm all right. How's it going?
No, well, thanks, man. I think it's a crescent fracture.
Yeah, perfect. That's it. It's a crescent fracture. Right, so those are the indications. Sacral pure dislocations or fracture dislocations. And then, of course, we also use the same technique for vertical sacral fractures and infrequently for fusion of the sacroiliac joint. And this is an example of a complete sacral body fracture, which is also translated or displaced. Now, so like I said, we're going to discuss only the percutaneous technique, and there are other ways of doing this. There is a CT-guided method, which is very infrequently practiced, and I mean, certainly, around the world as well. It's not a technique that most radiologists are comfortable doing. There is also computer navigation, which I have tried before. Yes, of course, it works and it works perfectly, but the amount of time it takes to set it up, it just, and of course, the capital outlay initially to buy all the equipment, in my mind, just really makes it not worth the investment. But of course, I think if you are it's pretty much like using the sure shot for distal femur screw placement in the nail. If you do the technique, frequently, you're going to be fairly comfortable and fairly quick doing it freehand. But of course, if you're not well versed, then the sure shot is there to help you, and of course, it's accurate. It's the same thing with the navigation. It's really for the infrequent surgeon. So we don't use it. So the technique that we use is the percutaneous fixation, which is fluoroscopic guidance, and this this is the landmark article that we most of us use just to familiarize ourselves with the technique. It can be done in the supine position or prone position, but what's important here is that you need proper placement of your patient on the table. This is an example with a Jackson table, which allows you to do your inlet and outlet views without any hitting anything at the bottom. But what's important is that the C-arm comes from the opposite side of the surgeon, and just make sure that, like I said, you can do your inlet and outlet view without much problems. So this is ideally what you're going to end up with. I'm going to show you how to get there. So this is, now the technique is moved on. So this is what's called now transiliac SI joint fixation. So it's from the one iliac wing to the next, through the, of course, through the sacrum. The older technique stopped, halfway through. But of course, now if you add this entire segment of sacrum, plus this cortex, plus this cortex, plus this cortex, the strength of your fixation is much, much higher than just a fixation up to the halfway mark through the sacrum. And also importantly, the question here is always now, how much are you compromising the other joint? And the answer is very little, if at all, because normal motion at the SI joint, remember that this joint has got lots of very strong ligaments. So normal motion is between 3 and 7% anyway. So you don't lose much in terms of movement. Certainly the patients don't complain of any symptoms, but there's a massive gain in terms of stability of your construct. And so now you move from using a screw that's going to be 100 millimeters to about 150 or 180 screw. So the, like I said, pull-out strength is greatly increased. And of course, now also we do S1 fixation as well as the S2 segment is also available for fixation. And what you see here is what's called the infix. So this is just another technique of fixing the anterior part of your pelvis. I don't use it often, so I use it only if there's an anterior lesion, but there is a bladder rupture as well, or a urethral injury, and that's what makes it, those patients are prone to sepsis. So we try and stay outside the body, outside the pelvis. So the infix puts screws in the anterior and inferior aspect of your pelvis, but the bar runs inside the skin, under the skin. Unlike the X-fix where, the pin is going to, of course, project outside, because the issue there is because of your soft tissue coverage, rate of sepsis of pin loosening is much higher in the pelvis. So the pins don't last more than 3 to 4 weeks and they become loose. So you need to remove them, whereas with an infix, they can stay on indefinitely. And so this is now when you introduce a guide wire, just showing you that when you cross the SI joint of the other side, you've got now this entire cortex, this entire bit of the ilium, and of course you've got this extra cortex. So you've got 1, 2, 3 extra cortices that you purchase with your screw, and it's even, of course, it becomes 6 cortices with your second screw. It becomes very important in osteoporosis fractures where this, I'll show you some images where the sacrum is basically just holes. There's no bone here, so you rely on these iliac cortices for the purchase. And this is just shows you. So your cortices, you start counting from this cortex. So it's going to be 1. So this is the entry cortex of the ilium. 1, 2, 3, and then 3 on the other side. And of course, in the middle of the sacrum here, you've got fairly good bone. Also, these images are just to show you that if you take an AP view of the pelvis, you won't see all these cortical lines. So you need to move the C-arm around so that you can isolate each cortex and each column that you want to see. And so this is the trajectory for the anterior X-fix, but also the trajectory for the pins if you're going to use the anterior X-fix. And this all, so this bony column is your ilium, and from there to there, that column is available. And that's what your screws are going to end up like, and that's your fixation at the end. So frequently asked questions, must you use 1 or 2 screws? Like I said, older literature said 1 screw. Biomechanical studies say 2 screws are stronger than 1 screw, but clinically they don't know. So the answer here is that if you are going to, so if you have an anterior lesion and a posterior lesion, you need fixation anteriorly and posteriorly. If for any reason you cannot put your anterior fixation, whether it's infection or soft tissues, then you need 2 screws at the back. That just gives you edge fixation. So minimum is 1, but of course, if you can't fix the front, then you must put 2 screws. Full thread or partial thread. Again, traditional teaching says if you have a sacral fracture where you don't want to compress nerve roots potentially, then you use a fully threaded screw. If it's a pure dislocation, you want to compress, then use a partially threaded screw. Our current practice is to compress with a partial thread screw, and then use a full threaded screw as a second screw to maintain the reduction, and that gives you far stronger fixation than just one screw. Length of the screw, so like I said, we used to only put a screw up to middle of the sacrum, but now we go transsacral. But of course, it's a new technique. There are some people who are still going to be against it. And then for bilateral injuries, there were different ways of doing this. People put one screw on the left and one screw on the right. But now, because you can do transsacral screws, you can do from one side only and cross to the other side. So this is an example showing you that, so like I said, initially, it would be a screw from this to fix this joint and end in the middle. And then, of course, you could stretch it as long as you wanted up to the end of the sacrum. So now all we've added is take this screw and cross it to the other side, and it gives you far stronger fixation. There is fixation here anteriorly, so one screw at the back is sufficient. Two screws obviously is stronger than one, but maybe not always required. But like I said, if for any reason though you cannot put a plate anteriorly, then you put 2 screws at the back. And then here, actually, this is like a last minute addition for this talk, because I mentioned this on Monday briefly, that if you have an AP pelvis, if you have any overlap at the symphysis, or not overlap, any step at the symphysis, it doesn't matter how wide this gap is. If there's a step, it means that your hemipelvis is rotated. And for it to rotate, it means that your entire symphysis is disrupted, and one of the bits at the back has to give way, like almost like a Montegia or a Cagliazzi. So it's often going to be a dislocation, like you see here, or it's going to be a sacral fracture. But this doesn't look so bad, it looks fairly benign. But if you see a step in the symphysis, remember, always look at the back, because there's going to be something at the back. So this is a very unstable injury. So for SI screws, you need pre-op imaging, and really what you want to see from your CT scan is whether you have enough of a window in your S1. And that's called sacral dysmorphism. I'll show some examples later. But you want to see that you can get a screw from here across to the middle, but ideally, of course, a screw from here right across. If you cannot, of course, here you cannot, because this is still dislocated and it's displaced. So you need to reduce it first. I'll show you how later on, and then run your screw. So always do a CT scan before you do SI screws. And like any joint, the primary goal is to, you want anatomic or near anatomic fixation, and it has to be rigid, and that's what the screws offer you. There is, of course, an option to use plates, but it's not, we use it only if we open, but generally we just do percutaneous screws only. Like I said, it can be supine or prone. Now, the beauty with this, of course, is that because it's percutaneous, it's not as prone to, in terms of your surgical timing, because if your patient is polytraumatized, it's funny because now, because we don't tend to be involved in the first night in the surgeries, this is not something we do acutely, but in many hospitals abroad where the trauma surgeons sleep in the hospital, they do the SI screws on the first night. Patient comes in, so they get a laparotomy and an SI screw, just as part of the initial, because also, remember if you're unstable in terms of hemodynamics, or even skeletally, it's the posterior lesion that is often more unstable than the anterior lesion. So if you can stabilize posteriorly, then it's your prognosis is better, and also it's easy to do close reduction acutely. But of course, for obvious reasons, we don't go in at night, so we tend to do this at a couple of days later. Now, advantages of percutaneous fixation, of course, are the same everywhere. The tissue planes are not violated, there's no tissue trauma, and you know the morbidity associated with surgical exposure is far less, and of course, like I said, it can be done in supine prone, and there's reduced blood position, reduced blood loss. But also, in a patient like this, if you wanted to do open reduction and percutaneous, open reduction of this pelvis, if you look at this, you can go posteriorly to the sacrum because this is all going to die off. It's going to be necrotic. You're going to be reluctant to open laterally, so you're just only hiding to nothing here. Whereas now percutaneously, it's going to be one centimeter cut here, and they get a screw right across without disrupting any of this. So it's very advantageous. But of course, as with all exciting things, there are a few catches along the way, and the structures at risk here, because this is your top of your sacrum. So if your wire comes out of the sacrum, you're gonna hit the vessels anteriorly. These are your common iliac vessels, and the L5 nerve root is right there, very close, and of course, like there's the rectum and everything else. So these are the things you must look out for. So there's your L5 nerve root. So the way we start, so this is the image that you get on the lateral view of the sacrum. So that's your L5 and S1. So what you want to see, you want this line here to be one solid line. It's called the iliac cortical density. This is the equivalent if you're looking at it from the front. So this is the line on the ilium. And what it means is that because of your slope of your sacrum, if you start above this line, say you start here, you will still catch the sacrum, but of course, in between here, there are structures in place. There's your L5 nerve root. So if you start here, you're going to come right into that. And when you do your X-ray, because the two bones overlapping, that one and that one, this space isn't visible as a space that doesn't contain bone. So all you see is just a continuous column of bone. And of course, you're going to start in the ilium and you're going to end up in the sacrum, yes, but the collateral damage along the way is massive. So you need to start below this density, which is what this line is. Okay, so now this is the density of the left side and the right side. And like I said, they need to overlap. So you need to adjust your tilt in the table until you have one solid line like this and not the two lines. Once you've got the one solid line, then this is your starting point below the density. So you're going to be starting below this line here. So this is where you're going to start. And like I said, if you start above the cortical density, that's your screw. Yes, it's in sacrum, but see what's happening here. It's gone through the L5 nerve root. And you know the result. Now, this is the bony channel that you're aiming for. So now this is your inlet view. So we've found our starting point on the lateral view. You've got your cortical density, so you introduce your guide wire. Then you go to the inlet view, which shows you the front of the sacrum and the back of the sacrum. Of course, if you exit at the back, this is your spinal canal, so you're not allowed to go anywhere near there. If you exit until in front, if you aim for this part, like I said, there's L5 nerve root, so you can't come out this way. So this bit, not available to you. This bit, not available. This is the only window that you've got in the sacrum in the middle here. So that's your fairway for the golfers. So on your inlet view, ensure that you can see the front of the sacrum nicely. Look here, there it is. And then that's your spinal canal at the back. Then you go to the outlet view. This is the top of your sacrum. And you look for the S1 foramina. 1, 1. So that's top of your sacrum, S1 and S1. So your trajectory is going to be between the foramina and the top of the sacrum. There's S2, S2. So you're going to go for the S2 screw. That's where the S2 screw goes. So again, that's your safe window in that. Then introduce your guide wire. So here we've placed it anteriorly. top of sacrum, S1, S1, and there's a wire going across on the outlet view, inlet view, bang in the middle. You can see this was from the days we're still doing only into the middle of the sacrum, but there's your screw going into the middle of the sacrum. Okay, so again, just in the view, second screw going on. This is now the S2, so that you can see here the S1 that's your S1 window. This is your S2 window. And the beauty with learning to do S2 screws is that most of the patients who have an abnormal S1 will have a very wide S2. So you can always use S2 instead of S1. And there's the screws going across. And like I said, the important part here is that you need to catch the outer cortex of the other side with your two wires. Screw, titanium, can be stainless steel, thread can be 16 or 32 if you're compressing, but also, like I said, you can then use a fully threaded screw just to protect your compression. And that's your end result. No, it's in fact, I was teasing Sonepu that it took me years to to learn to put the S2 screw, and and now because we do it so routinely that within a couple of months he's now doing the S2 screw without even thinking about it. But it's a nice technique to do, but there's still a learning curve attached to it, associated with it. And of course, as with most things, once you figure it out, everything just falls into place. But because of the structures at risk, it's something that you mustn't take for granted when you do it. So checklist preoperatively, like I said, you need a CT of the sacrum, supine or prone position. Table has to be radiolucent. You don't have to have a Jackson table. You just need to pull your patients a little bit down. I use a trolley sometimes for the feet, just to get the inlet and outlet view. You need a good C-arm. So I used to give them a bowel prep preoperatively to clear the bowel, but that was with the older C-arms. I mean, the new C-arms now are quite good in terms of resolution, so I don't do this anymore. But sometimes, of course, patients will still have lots of gas in the abdomen, and I just use my fist to try and thump that out of the way. And of course, you must have instruments for reduction. Now, so this is the inlet view, and the way to know that it's reduced, you need to recreate this curve here. So this pelvic brim needs to be recreated, and you can see this is reduced. So as long as it's lined up, that's perfect. It can open up a little bit because the screw is going to compress that. But if there's a step here, it's difficult for the screw to correct that because you're going to have to come from a very abnormal angle just to try and counter that. And of course, you're going to exit the sacrum. So a gap is easy to correct with the screw only, but a step is not that easy. Again, play with your views. So you see here from this, you can see how it's open here, and just with the screw only, you can then close it. And ensure that you've got a washer in young patients with good bone, and that your screw is right against the cortical line. Again, play with your C-arm views. And with all orthopedic operations, you need your correct instrumentation to make your job easier. There's an example where now, see here, there's a step in the sacroiliac joint. So percutaneous reduction doesn't work for this. It's very difficult. You can attempt traction on the leg, but remember this is the inlet view. So this has gone posterior, this is anterior. So you can put something on the iliac wing to try and lift it up. But like I said, it's often very difficult, and the only way to correct this is by opening and putting a clamp. And once you've reduced it, then your screw goes across. Now this is just an example of what sacral dysmorphism looks like. Remember, I've always I said now you need to get into S1, but sometimes S1 looks abnormal. This is an abnormal looking S1, and if you try and go transsacral, you're going to exit the sacrum. But see how wide the S2 window is here. So whenever there's sacral dysmorphism, then S2 is often the better way to reduce them. And there are pointers of dysmorphism on X-ray, like if your L5S1 disc is at the level of the iliac wing, of your iliac crest, that's a sign of dysmorphism. Abnormally formed transverse processes, as you can see here, a very abnormal zigzag shape to the sacroiliac joint, and abnormally large foramina. This is an abnormally large foramina for S1. So those are all signs of dysmorphism. But of course, you must do a CT scan to properly plan for your windows. And then the other thing is a sacral slope. So this is almost very similar to the 3 types of the acromion, where it's concave, flat, or convex. So normally, this is what your sacrum is shaped like. There's a nice gentle slope up here and then goes down. And of course, the L5 nerve root, like I said, is often very closely applied to your anterior part of the sacrum. So, which stands to reason that if your sacrum is curved the wrong way, so see, it's meant to be type 1 acromion or like that, but if it goes the wrong way, where it's curved, because remember this bit remains the same. So when you screen, you don't see this curve, this concave, this empty space here. You see that bone, and it looks like it's one bony column. But if the slope is wrong, then the L5 nerve root follows the concave. Now the screw is inside, but of course it's gone through the nerve root. So you must always have a CT scan and quantify that you've got enough space on the sacrum. If not, then you must change the trajectory of your screw to only where the bony column is and not across. Okay, this is just again just clinical examples now of starting off. So S1 and S2. This is an example where an S1 transsacral screw is not possible because this would exit there. Then of course the S2 is always nice and wide. And again, so this is called the obturator inlet view, to just make sure that you can see the outer cortex of the ilium and your screw rests against that. So I'm hoping I've answered your questions, and we spoke about partial versus fully thread. Like I said, fracture of the sacrum, fully threaded, and if it's a dislocation only, partially threaded. Length of screw we've discussed. So here I wanted to show you just a CT scan of the sacrum in an elderly patient. So this is someone that's osteoporotic. Now, if you are trying to put an SI screw here, really the only cortex to speak of is a little bit in the ilium here and a little bit in the sacrum here, but there's nothing here, absolutely nothing. So the screw, doesn't hold as well. Whereas if you add this cortex to the sacrum and you go right across, now you've got an extra 2 cortices, 3 on this side. So your fixation is that much stronger with a transsacral screw versus a screw that traverses only one joint. Length of screw we've discussed. Now here again just shows you the importance of having a long screw. This is a sacral fracture, and this is my complication. See how short the screw is now. To think that you're going to control a whole sacral fracture with a screw that just crosses the fracture line, that's just a recipe for disaster, as I learned unfortunately here. And I imagine if the screw had started here and gone all the way across. So this is what I meant when I referred to bilateral injuries, that we used to come from one side, one screw for this side, and then change sides and one screw for this side. But this is hopelessly inadequate. Whereas nowadays what I would do is just take a transsacral screw from one joint right across to the other side. And for this, I would put 2 screws because it's a dislocation and a fracture. So the advantage of a transsacral screw is that it's transsacral, transiliac. So you've got your load which is distributed across the entire length of the screw. You've got more threads that engage in the bone, and of course more cortices that you're using. So 2 screws. Now you can put 2 screws in S1 if there's enough space, but of course now it's much better to put 1 screw in S1 and 1 screw in S2 just to distribute your load evenly. And says so 2 screws increase rotational stiffness and load to failure. Bilateral injuries, we've just discussed this. So so to summarize, it's important to appreciate posterior lesions, and pre-op planning is crucial. And of course, complications are devastating if they happen. So your execution needs to be absolutely precise, and your fixation needs to be biomechanically strong so patients can weight bear immediately. And that's the beauty of transsacral screws, that as some of you will have noticed, we don't do partial weight bearing anymore now. If you've got transsacral screws, I just let them walk as within the comfort levels, and we've not seen any screws back out or break or any loss of position. Right, thank you. So I will take questions, and I think, I know that I promised you one more talk, but I think we must leave that for later in the year or early next year. Yeah, so I'll take questions now.
Yes, Prof, I do have two questions.
Yebo.
So the first question is for the infix.
For the infix.
Yes. Do you remove it later on, or you just leave it? That is the first. And the second thing is,
yes. So the answer is yes. It has to be removed. The thing is, it's very uncomfortable for patients because it's still fairly superficial and it's bulky hardware. So the patient will feel it and they dislike it immensely. So you always have to remove it. And if you don't bury your screws or hardware deep enough, then you can get soft tissue breakdown over the screws. So yeah, it needs to be removed. And also there's quite a high incidence of lateral cutaneous nerve, lateral cutaneous nerve of the thigh injury with the infix.
And the second question is, if you accidentally, if you hit the L5 nerve root and you discovered after the patients in the ward and all these things, do you go back and try to remove the screw, or you just leave it like that, or what is the bill out exactly?
Look, so firstly, when you do the screw, you must keep an eye on the leg, important, or the foot. Just make sure that there's no movement there. And if the foot moves, you change your trajectory. If you discover it post-op, then I send them for the routine imaging, X-rays, inlet and outlet views. And if there's any doubt, then you must CT scan them. But there's very little value, or there's very little to be gained from removing the screw if it's well placed, because then what it means is that you may have hit the nerve with one of your wires initially when you were trying to find the correct position. But if the final screw placement is correct, then there's no value in removing the screw. It's only if it's misplaced, and then of course you must remove it. But if it's well placed, you don't need to remove it.
Yeah, thanks.
Okay. Any other questions? None. Or maybe just give me 5 minutes. I just want to see if I can find the presentation with for Jonathan with the gull wing sign. So just give me 1 second, please. Which screen can you see? Can you see the presentation screen?
Yes, Prof.
Okay, let's see if we have it here. I hope we do. I hope we do. Look, I'm not going to go through this. We'll do it next time. Is it obvious here? No, no, no. That's all posterior wall. Close enough. No. Sorry, guys. Okay, this is the closest you're gonna get now, Jonathan. So if you look here, it's a picture now that this cartilage is not so well defined here, but basically what happens is that you get this cartilage here, right? The dome, can you see this dome here? So you get that, and then you get the impaction and the medialization. So in the end, you're left with the sign like this and like this. So almost like the gull when it flies, or the Mercedes-Benz doors when they open the gull wing doors. Is Jonathan still there?
Yes, Prof, I am here. It was Dane who wanted it, but I am also very interested.
Oh, it was Dane, yeah, sorry. So yeah, so look, I mean, unfortunately, as I said, it's not the best image that I can think of right now, but I'll definitely make sure then to show it to you maybe next Monday morning, guys, for everyone else that's interested. But basically, it just signifies dome impaction. So as the patient falls and lands on the trochanter, the femoral head hits the dome and medializes. So this part of the dome gets impacted and medialized. So you get an impression fracture on the dome like this, like a gull wing. And let me just, maybe if I continue in this presentation, there may be something else. Let's see. Okay, if you look at the CT scan, okay, so this is typically what you get, but now this is not, no, you don't often get like such a gap between the two. It's often just a displacement in that plane, but wait, maybe we gotta try one more time. It's a young patient. Again, I can see it here. Again, it's the, now this is, but unfortunately, it's not so typical. But this is what you get. That's the dome, and that's the bit that's impacted here. Can you see this part here? So that's impacted. So that's your gull wing sign. Let's see if I can find another better one. Now, so I promise I'll do it on a Monday morning. I'll show you guys on a Monday. I'll find a better example of that. Okay, so shall we end it there? Any other questions?